Hello everyone, this is Dr. Agalya. We are going to discuss about amniotic fluid and its disorders now. So, first we will see what is amniotic fluid. Amniotic fluid is that fluid which surrounds the fetus and it is seen in the amniotic cavity, right? So, early in pregnancy, we have two cavities, namely the amniotic cavity. This is the yolk sac, okay, and another cavity is we have the extrachorionic cavity or the extracoelomic cavity. Okay, so this is the amniotic cavity. What happens is by 14 weeks of gestation, there is fusion of the membranes, amnion and chorion. Now, as this fusion is going to happen, the chorionic cavity is going to get obliterated and the cavity which is going to remain is the amniotic cavity. Okay. So, first we will see why this fluid has to surround the fetus. Okay. What are the functions of this amniotic fluid? Number one, this fluid surrounds the fetus and acts as a shock absorber. It also helps in maintaining the temperature around the fetus. It helps in preventing the fetus from the infections also. So, it is basically bacteriostatic. And next point is, as the fetus is growing, it needs space for growth and movements. So, this space is also provided by the amniotic fluid for growth and movements. Okay, the space is provided. So, this is early in pregnancy. It helps in forming a wedge of the membranes amnion and chorion. So, the necessary pressure for expulsion is provided. Also, when there is so much of pressure during labor that is acting from the uterine cavity and the uterine cavity is getting compressed, there is a chance of compression of the umbilical cord also. So, it protects the umbilical cord from compression. Okay. So, these are some of the important functions of the amniotic fluid. Next, we are going to see. So, these are some of the functions of the amniotic fluid. Next, we are going to see how this amniotic fluid is produced. In early pregnancy, amniotic fluid is obtained as a transudate from maternal plasma through the decidua. And in the second trimester, trans rate during second trimester, this is obtained as a trans rate from the fetal plasma through the fetal skin. So, usually the fetal skin keratinization happens between 22 to 25 weeks. Okay. So, until this period, the fetal plasma will be an important source. But however, the major source in the later pregnancy is very important. It's the fetal urine. Fetal urine is seen to contribute to the amniotic fluid from 18 weeks itself. And by 22 to 25 weeks, as fetal keratinization happens, during this time, fetal urine is the main source of energy. And fetal urine starts reducing just 2 weeks prior to labor. And also, during this late pregnancy, fetal respiratory fluid also contributes to some amount of amniotic fluid. Okay. So, what are the contributors? Amniotic fluid is being contributed by number 1 is fetal urine, which contributes about 1000 to 1200 ml, and the second contributor is fetal respiratory secretions, which contributes about 170 to 200 ml, and the next contributor is the fetal nasal and oropharyngeal secretions, which contributes about 17 to 20 ml. Okay, so these are the major contributors. Now, if we see the amount of fluid in various gestational weeks. So, this is gestational age in weeks, and this is the amount of amniotic fluid in ml. Okay. So, let's take this number. It is 12 weeks, 16 weeks, 18 weeks, 34 weeks, 40 weeks, and even 42 weeks, that is post-term. So, the amount of fluid at 12 weeks will be 50 ml, at 16 weeks it will contribute about 200 ml, at 18 weeks it will be 800 ml, and at 34 weeks it is 1000 ml, and by 40 weeks by term it is going to reduce again, because the fetal urine contribution is also going to reduce, right. So, it will be again back to 500 ml, and by 42 weeks there will be only 200 ml of amniotic fluid. Okay. So, what is the important point you have to know here is the maximum amount of amniotic fluid is seen around 34 weeks of gestational age, where it is about 1 liter. Okay. And by term this is going to start reducing, and by 42 weeks there will be only 200 ml of amniotic fluid. Now, what are the other composition of amniotic fluid? Basically, it consists of water to the maximum. Okay. So, remember, there is no nutritive function that it can provide to the baby. No nutritive function. Second point, it consists of carbohydrates, electrolytes, enzymes, proteins, etc. It is composed of glycoproteins like phosphatidyl inositol, phosphatidyl glycerol, lecithin, sphingomyelin. It also consists of enzymes like estrogen, progesterone, beta HCG, PAPA, pregnancy associated plasma protein A, etc. Okay. So, these are the basic compositions. Then, some of the characteristics of amniotic fluid. First, we will be noting the color of amniotic fluid, right? So, color of amniotic fluid in early pregnancy, it is basically colorless. And in late pregnancy or term, this becomes a straw colored fluid. Okay. So, there can be some of the pathologies you can be able to identify using this color change. Number one, if it is green in color, it is a meconium stained fluid. Where there will be fetal distress, and that fetal distress had led to the passage of meconium by the fetus, and that meconium had stained the amniotic fluid. And next one, it can be a golden yellow color, usually due to presence of biliverdin. This biliverdin will be seen if there is any hemolysis is happening, and this hemolysis cause will be usually RH incompatibility. Then there can be dark colored amniotic fluid or tapioca like amniotic fluid. Tapioca like amniotic fluid is usually seen in greenish yellow amniotic fluid, can be seen in postterm pregnancy. There can be dark colored amniotic fluid, which is basically due to any bleeding that is happening. For example, if there is a chronic abruption, and tapioca color amniotic fluid is seen in intrauterine death. Okay. So, this is about the color. Next, pH of amniotic fluid is basically alkaline. It is between 7.1 to 7.4 usually. So, this alkaline nature is very important in distinguishing the cases of PROM, where you have to distinguish between amniotic fluid excretion and the vaginal fluid. So, amniotic fluid is basically alkaline in nature as we have already seen, and vaginal fluid is usually acidic in nature with a pH around 4. So, this test is used in nitrogen and this test is basically seen in litmus paper test. It basically consists of growth factors and also some of the cells like fibroblast, stem cells, fetal, epithelial cells also. Okay, we'll see the characteristics of amniotic fluid. Basically, amniotic fluid in early pregnancy is clear in color, whereas in late pregnancy this becomes a straw color. We'll see some pathologies also. Suppose if it is a green colored amniotic fluid, then there is meconium staining, and this happens in case of fetal distress. Suppose if there is a golden yellow amniotic fluid, it is usually due to the presence of biliverdin, and this is seen in hemolysis, which again happens in RH incompatibility. There can be greenish yellow fluid in case of postpartum pregnancy. Dark colored amniotic fluid is seen in case of hemorrhage, that is happening in cases like abruption, and tapioca colored staining of amniotic fluid is seen in case of intrauterine death. The next property you have to know is about the pH of amniotic fluid. pH is usually between 7 to 7.5, which is alkaline in nature. Okay. Now this property is used in case of doubtful PROM to distinguish amniotic fluid from vaginal fluid. Because vaginal fluid in pregnancy is usually acidic in nature, where the pH will be around 4. Okay. This property can be used in litmus paper test. And the next property is the specific gravity, which is around 260 to 280 milliosmoles per ml of amniotic fluid. Okay. Now, what are the sites of absorption of amniotic fluid? Basically, it is removed by swallowing, then intramembranous transfer across the fetal membranes, and then transmembranous transfer across the decidua. Okay. Swallowing is the main mode of removal of amniotic fluid. Now, what are the ways to measure amniotic fluid? How to measure amniotic fluid? See, there is a most specific way of amniotic fluid measurement, which is dye dilution test. But the disadvantage of this test is it needs amniocentesis, and that becomes an invasive procedure to do, which is not possible for us to give the woman an invasive procedure every time, and this will increase the chances of infection in her. So, this is not routinely used. What we routinely used is measuring amniotic fluid by using ultrasonogram, which is a semi-quantitative method of measurement. Okay. So, what are the two parameters we see in ultrasonogram? Number one is the single deepest vertical point, and number two is the amniotic fluid index. Okay. So, how we measure this? Basically, we divide the uterus into 4 quadrants for measuring amniotic fluid index, and we take 2 landmarks for this. For number one is umbilicus, through which we draw a horizontal line, and the vertical line is drawn through the linea alba. So basically we get 4 quadrants, okay, and we have to measure the maximum vertical pocket in each of this quadrant, okay, excluding the fetus and the umbilical cord lobes, okay. Then if you add all the 4 vertical pockets, we will be getting amniotic fluid index, okay. So this is the most reliable and most reproducible method of measuring amniotic fluid. Whereas in measuring single vertical pocket, we will be considering the uterus as a single cavity and measuring the deepest vertical pocket here. Okay, so this is not that much reliable. What are the normal parameters of this single vertical pocket and amniotic fluid index? Okay, I'll be telling it in centimeters. Single vertical pocket normal ranges between 2 to 8 centimeters, and AFI values are between 5 to 25 centimeters, right? So, based upon this volume, if there is less than 2 centimeters of single vertical pocket, and if the AFI is less than 5 centimeters, this condition is known as oligohydramnios. Suppose if the SVP is more than 8 centimeters and AFI is more than 25 centimeters, then this condition is known as polyhydramnios. Yes? Now, we'll see about oligohydramnios. What is oligohydramnios? It is basically there is less amount of amniotic fluid. Suppose if there is no measurable vertical pocket of amniotic fluid is present, then this condition is known as anhydramnios. Okay, and oligohydramnios complicates about 1 to 2% of all pregnancies. So, what are the clinical implications if we have less amniotic fluid? What are the causes of oligohydramnios? Most of the time, the causes idiopathic, or there can be any fetal anomalies, okay, especially the renal anomalies like renal agenesis, autosomal recessive polycystic kidney disease, multidysplastic kidney, there can be bladder outlet obstruction or genitourinary anomalies like persistent cloaca, cyanomelia, etc. Abnormalities can also be seen in the placenta, like preeclampsia or any vascular disorders, placental hematoma. There is one sequence called chronic abruption oligohydramnios sequence. Okay, where there is small amount of abruption that is happening over weeks, and that will also present with oligohydramnios. Okay, so this can also contribute. And maternal conditions like hypertension, autoimmune disease, especially PROM, that is premature rupture of membranes, and postdated pregnancies should also be ruled out. Okay, and the fifth point is about the drugs. If she stays taking any drugs like AC inhibitors, ARBs, that is angiotensin receptor blockers, and NSAIDs, these drugs can also cause an adverse effect of oligohydramnios. What are the clinical implications of having oligohydramnios? Number 1, they may seem as small for gestational age uterus. Okay, they can be associated with FGR because the common pathology for FGR and oligohydramnios in this condition can be uteroplacental insufficiency. So this may give rise to FGR also as well as oligohydramnios, and there can be skeletal abnormalities like CTEV. It can give rise to one specific sequence known as Potter's sequence or syndrome. So this is the Potter sequence or syndrome. What is going to happen here is there is bilateral renal agenesis or bilateral multicystic dysplastic kidneys that will be leading to reduced fetal urine excretion, and that will be resulting in fetal oligohydramnios and causing fetal umbilical cord compression. Okay, so the features what you will see is known as Potter's faces, and in this Potter's faces you can have low set ears, there is a beaked nose, there is prominent epicathic folds, that is downward to slant eyes. Then there can be pulmonary hypoplasia that can cause respiratory failure, and there can also be limb deformities like CTEV. Okay, so this sequence can happen. And another one is there can be pulmonary hypoplasia. Okay. Now, how we can identify oligohydramnios clinically? Basically, there is a small uterus compared to the period of gestation. Okay, and this small for gestational age uterus can happen with oligohydramnios, placental insufficiency, especially in cases of FGR, intrauterine death, transverse lie. In some cases, you have to also rule out miscarriage if it is happening early. Okay. So, the other point you will be seeing clinically is the fetus will be closely surrounded by the uterus. Okay, it will be just like it has been clamped by the uterus so that fetal parts are easily palpated. Okay. So, what are the investigations we can do? Investigations may include the first and easily approachable thing is ultrasonogram. As we have already seen, we will be measuring the amniotic fluid by either SVP or amniotic fluid index. This is preferred. We will also check if there is any fetal anomalies. In this case, you have to even do the chromosome number, you have to even check the chromosome number. Then, placental abnormalities should also be checked. We can go for Doppler of the umbilical artery. Normally, at term, the ST ratio of umbilical artery is around 2. Suppose if it is increased, then there is abnormality. Suppose if it is increased, there is abnormality and need for pregnancy termination. Okay. So how will you manage oligohydramnios? Number one, we can do non-invasive method, like we can ask the mother to increase her fluid intake up to 2 liters per day. We can go for second, we can go for IV infusion of saline. Third point, we can go for amnio infusion. Okay. Amnio infusion during pregnancy, if it is done, it can be done transabdominally. If it is done during labor, then it is done transcervically. But this has only shown improvement only when there is further monitoring of perinatal outcome is done in a good setup. Okay. Otherwise, we can go for pregnancy termination if there are any adverse outcomes expected through this pregnancy, or if we see any Doppler abnormalities. Okay. Next we will see about polyhydramnios. Polyhydramnios means there is more amount of amniotic fluid than the expected cutoff. Okay. It can be divided into mild, moderate and severe polyhydramnios based upon the single vertical pocket and EFI measurements. Okay. If single vertical pocket is between 8 to 9.9 centimeters, it is mild. 10 to 11.9 centimeters, it is moderate polyhydramnios. And if it is more than 12 centimeters, it is severe polyhydramnios. And if the amniotic fluid index is between 25 to 29.9, it is mild polyhydramnios. 30 to 34.9, it is moderate polyhydramnios. And if it is more than 35 centimeters, it is severe polyhydramnios. Now, most of the time, the polyhydramnios is mild and it is seen in 22/3 of the cases, and it is usually due to benign causes or idiopathic. What are the other causes that are leading to polyhydramnios? Conditions in which the fetal swallowing is affected, for example, anencephaly, hydrancephaly, cleft lip, cleft palate, micronathia. Second one, there can be conditions like diaphragmatic hernia, second one, it is seen in conditions like diaphragmatic hernia, pulmonary sequestration and congenital adenomatoid malformation. Third set of conditions include high cardiac output conditions like thyrotoxicosis, Epstein's anomaly, then tetralogy of Fallot. Some of the gastrointestinal conditions like esophageal or duodenal atresia can also contribute to polyhydramnios. Other causes may include hydrops fetalis, arthrogryposis, myotonic dystrophy, sacrococcygeal teratoma, placental chorioangioma, and even in maternal infections it is seen. For example, cytomegalovirus infection. Also, it is seen in maternal diabetes. Here what happens is there is maternal hyperglycemia which will be leading to fetal hyperglycemia. So this is leading to increased fetal diuresis, and that again leads to polyhydramnios. Another condition is multifetal pregnancy. For example, if it is complicated with TTTS, which is twin-to-twin transfusion syndrome, it can lead to increased amount of amniotic fluid, which is polyhydramnios in one twin, and oligohydramnios, decreased amount of amniotic fluid, which is oligohydramnios in second twin. Okay. Now, what are the clinical features? Number 1, the uterus becomes more distended. That is what we see clinically, right? So, fetus is easily ballotable. Fetal parts are not palpable. Fetal heart rate is not that much audible also, and in these cases fluid thrill can be elicited. Okay, so what are the complications? Especially since there is over distension of the uterus, the mother can present with breathlessness and abdominal pain, especially if the increase in fluid is seen with an acute onset. Suppose if it happens in a slower onset, then there won't be much symptoms. Since there is over distension of uterus, there is more pressure inside the uterus, right? So that can lead to preterm labor, premature rupture of membranes, and as the fluid overflows, there will be cord prolapse, placental abruption, because most of the fluid comes outside, there comes a negative pressure inside the uterus. So this will lead to separation of the placenta from the uterine wall. This can also lead to uterine inertia and postpartum hemorrhage. So what are the investigations we will do? As we have already seen, the easiest mode of investigation is ultrasonogram, where you will be measuring SVP and amniotic fluid index. And the second important investigation you have to do in case if you have a hydrops fetalis is, if it is an, you have to rule out whether it is due to immune cause or non-immune cause. Okay. To rule out the immune pathology, we have to do the maternal screening for D, K and kill antigens, even the C. And in non-immune hydrops, we have to check the infections in the mother. Namely, you have to check syphilis, cytomegalovirus, parvovirus, then toxoplasma also, even rubella. Okay. How will you manage polyhydramnios? Basically, close observation of the pregnancy is needed. Okay, that you can do it by performing non-stress test and amniotic fluid index, okay, which is basically the modified biophysical profile every 2 weeks, or even if needed weekly, and you can give them steroid coverage, okay, either by betamethasone or dexamethasone. What is the dose? In betamethasone, we will be giving 2 doses 12 mg IM 24 hours apart. For dexamethasone, we will be giving 4 doses 6 mg IM 12 hours apart. Okay. Suppose if the pregnancy is less than 32 weeks, in this case, you can give a drug called indomethacin, which is a prostaglandin synthetase inhibitor. This drug can be given in 2 kinds of regimens. Number 1, where you can give 25 mg dose every 4 to 6 hours apart. Number 2, you can give it as a 75 mg dose every 12 hours apart. Okay. What are the side effects of the drug? There will be nausea, epigastric discomfort, and closure of ductus arteriosus. So, due to this reason, you should never give indomethacin after 32 weeks. Suppose if the pregnancy is between 32 to 34 weeks, you can go for therapeutic amnio reduction. Okay. In one setting of amnio reduction, you can remove up to 2 to 2.5 liters of amniotic fluid. Okay. So, this is done especially in case of fetal anomalies and fetal TTTS if present in multiple pregnancy. And suppose if the pregnancy is more than 34 weeks and there is polyhydramnios, You can even counsel the mother about preterm labor. But you have to assure that you have covered the steroid dosage. So this is all about amniotic fluid and its disorders. Until we meet in the next video, take care and bye-bye.